Okay. Where do cats wait to pay their bills? Where do cats wait to pay their bills? Any guesses? Is tired from last week's exam? In the feline. Okay. All right. Why are animals in the ocean so healthy? Why are animals in the ocean so healthy? They get a lot of vitamin C. Very good. Nicely done. Let's give her a round of applause. Yes. Okay. What kind of fruit has the most electricity in it? What kind of fruit has the most electricity in it? Is it A and B only? That was a bad joke, wasn't it? What kind of fruit has the most electricity in it? A watermelon. Aha! All right. Well, I should stick to pathology, huh? Okay. So, we're going to pick up kind of where we left off. The transition is we touched on hypersensitivities in Unit 1, but we didn't go into great detail. And I kind of explained to you why that is, because over the years, I've tried to move things around so the units are a little bit more palatable. And so now we're going to get into a lot of the details associated with the different types of hypersensitivities. And so how many hypersensitivities do we describe? How many do we characterize? 4. Okay, and they're labeled what? Hypersensitivity 1. Right, you ready for this? Hypersensitivity 2, hypersensitivity 3, and then hypersensitivity 4. Nicely done. You guys have retained a tremendous amount of information since Unit 1. Okay? So now we're going to build on that. We're going to talk about this autoimmunity, and we're going to launch into hypersensitivity. So let's first characterize what it is. So hypersensitivity is just like the word sounds. It's an oversensitive reaction or an oversensitization. It's too much. But it's too much of a good thing. Because your body uses this mechanistic process in order to combat invaders. But the problem is the response is too much. It's hyper. It's overactive. So it is an immune response, but it's an immune response that's inappropriate. Okay? So the inappropriate nature of the sensitization causes subsequent tissue damage. Is there inflammation involved? Absolutely. How many of you had like watery, itchy eyes because you're allergic to X, Y, or Z? How many of you have allergies? Is anybody allergies acting up right now because it's windy? Like, I don't know what it is, but there's something in the air that I actually had to take an IgE blocker essentially this morning, right? An allergy pill. So I had to take an antihistamine this morning because my allergies are just weird. I don't know. I don't really have bad allergies, but for some reason the last couple of days it's been bad. So when you have an allergic response, let's say to pollen in the air, or how many of you are allergic to like cats or dogs or hamsters or guinea pigs, or how many of you are allergic to certain types of foods? Okay? Is your hand going to stay up this whole lecture? Are you allergic to everything? Yeah, a lot. So when you have an allergic response, let's say to like a cat or a dog, or let's say it's pollen, what happens to your eyes? They get watery, they get itchy, they get red, right? That's an inflammatory reaction. So it's causing tissue damage, right? The sensitization that takes place is inappropriately triggered, and then it's elevated and it's maintained, or it's chronic in nature. And first, the individual has to be exposed to it for them to develop what's called sensitization. But on the second exposure, now it's heightened and it actually is maintained for a long period of time. So the 4 different types that we just described in broad brushstrokes, so we can get into more detail, are shown on this one slide. All 4 of them are on this one slide. So this is actually a really great study tool because it's a single slide that you can quiz yourself on to see how well you know these different hypersensitizations. So type 1 is an IgE-mediated response, and we make immunoglobulin E in high levels. And there are certain individuals that actually make more IgE than average. So they tend to be people that are more susceptible to allergies. And we call these atopic individuals. And so their genetic makeup produces or influences IgE production to be elevated, more so than what it normally would. IgE, though, in all reality, is the lowest in the bloodstream under normal circumstances. But it's the one that mediates all these allergic reactions and allows for our body to respond to them, as well as parasitic invasions. Now, type 2 is what we call antibody-mediated. Antibody-mediated where there's a tissue response or a very specific antibody that actually is released, and we're going to see an example of where it goes in bodies. Some examples of type 2 are not allergies. Allergies all fall under type 1. But type 2 are going to be things like blood transfusions. So if you donate blood, how many of you donated blood or you received blood? Because you had a surgery or you were in a traumatic accident. So those blood transfusions, we actually have 2 antigens that we care about, mostly. There are many other antigens on red blood cells, but there's only 2 that we really focus on because the other ones aren't necessarily lethal. The first one is antigen A, and the second one is, or the first category is antigen A or antigen B. So you can either express antigen A or you express antigen B on the surface of your red blood cell, or you express both. Or in some individuals, you don't express any of them, and that would be blood type O. So if you're type A, you express antigen A. If you're type B, you express antigen B. AB, you express both. And if you're type O, you don't express any antigen. Then there's another one called rhesus factor. And the rhesus factor is also a surface antigen that's expressed or not expressed in individuals. And if it's expressed, then you're Rh positive. If it's not expressed, then you're Rh negative. Okay? And as you can imagine, those antigens, if you see it for the first time, and you don't have that antigen, you're going to make an antibody towards it. And so the second time you see it, you're going to go attack it. And that's why we have to pay attention to your blood type. And so you know you're probably A positive or negative, B positive, negative, AB positive or negative, or O positive or negative. And the blood bank is always in need of type O negative blood. Anytime. Why is that? You're the universal donor. Okay, so your blood can be used for anybody if you're type O negative. Okay, so that's the one that's usually at the top of the list as far as examples for type 2. Type 3, we form a complex. And we'll talk more specifically, I'll show you pictures of what we mean by these complexes. But type 3 is not just the antibodies circulating around, but you have an antibody that's produced, it finds the antigen, and that complex floats around in the bloodstream, and then it gets stuck in different locations. It gets lodged in different locations. And in type 3 with this complex, some examples are going to be like lupus, okay? And we'll talk about other ones as well, but just giving you some early examples as we get teed up for the rest of the afternoon. And then type 4, the last one, is very different than the first 3 because it's T-cell mediated. The first three involve B cells, antibody mediated. And then in type 4, it's T cell mediated. Now in some examples, we actually might see antibody production. But if we see antibody production, it's usually not without a T cell response. So it's a cytotoxic T cell response. And then there are maybe helper T cells that stimulate B cell populations to manufacture antibodies in a type 4 type of response. But because the T cells were present from the beginning, it's already categorized as a type 4. Okay? So it's kind of the easiest one of the 4 to remember because it's the only one that really involves T cells. So an overview slide, and I think it's actually very helpful from a studying standpoint. So if we look at, in order today, we're going to tee up type 1. We'll talk about allergies, and then we'll move to types 2, 3, and 4. Okay, and then we'll take our break and come back. So type 1. Type 1 is IgE mediated. So this is in the lowest concentration in the blood under normal circumstances. But it's the one that's produced in abundance in response to some sort of allergen or some sort of antigen that's going to stimulate this cascade of events. So what are the cascade of events that take place? Well, first, let's say, for example, we have a type of allergen, like pollen. It's going to come across the mucosal lining, like of the nose. It binds to a B cell, and it activates this B cell. As that B cell activates, it begins the production of IgE. And that IgE starts to stimulate the catalyst of events, ultimately that's going to lead to the release of certain types of chemical signals, cytokines, primarily histamine. So the number one chemical mediator of this IgE cascade of events is the cytokine histamine. But there are others, but that's the main one that gets things going. And that's why if you have allergies, and it's allergy season, you take a allergy pill that's called an antihistamine. And it blocks the release of that histamine response. Now we know that histamine is a potent vasodilator, right? We know that from our inflammatory lectures. We know that as a vasodilator, it stimulates blood flow to move into the tissue. That's where you get the redness and the swelling. That's where you get the extra fluid. That's why the nose and the eyes start to run or water. The sensitization process that we mentioned earlier, this is something that requires an initial exposure to the allergen. And the initial exposure may actually have very few clinical sequelae. There may be not any allergy responses. It's just creating a memory response. So the next time you see that allergen, your response is immediate and it's orders of magnitude larger than it was the first time. So that's the sensitization that takes place. Okay? And sometimes this takes place in individuals that visit an area. They go on vacation to an area, then they come back home, and later on they go back to that area, and now all of a sudden they're allergic to everything that's in the region. Because they were sensitized on their first trip, and then they never saw it again until years later when they went back on vacation to that location. That happens in Arizona quite a bit. The other thing to note from this slide is we actually have an immediate response as well as a late phase response. And the immediate response that we're going to look at on this next slide is due to things that are dumped out immediately. Due to things that are dumped out immediately. So what are they dumped out of? They're dumped out of mast cells. So now if we have been sensitized, and we're talking about the second exposure, which is, for the most part, for all of us, that's now. As an adult, you have likely realized the things that you're allergic to. There's very few things that you're going to come across unless you go into a whole new region of the world, or you try something that you've never tried before, like a food that you've never had, and you become sensitized, and the next time you discover an allergy. But some other types of sensitizations, how many of you are allergic to bees? Is there anybody in the room? I got one bee allergy, that's it. Some of you are like, I don't know, like when they come around, I leave, right? That's a good idea. You know, I like try not to get stung, okay? You don't want to do that experiment? Oh, right? Oh, I guess I'm not allergic. Well, you have to find out the second time, right? So the first time you get stung by a bee, usually what happens as a kid, you get stung by a bee, and it kind of swells up more so than what you normally would have expected. So your parents are kind of like, well, that looks really weird. For a bee sting, that's pretty aggressive. And then parents are thinking about it. Might take the kid to the pediatrician, and then the pediatrician says, well, we can test for this, but likely they have a bee allergy, right? Keep them away from bees. And then if it's really aggressive, they might issue like an EpiPen. Or you can have Benadryl on hand if you can get there fast enough. But the second time you get stung by a bee is usually when it's clear that you have a bee allergy. And what the pediatrician will say is, it's going to grow. Every time your child gets stung, it's going to grow. So after the second time is usually when the EpiPen gets prescribed, okay, and then mom carries Benadryl in their purse, okay? So bee allergies, to venom, to medication allergies like penicillin allergies, allergies to food, allergies to pollen, allergies to environmental things like air pollution. All of these types of things are a type 1 IgE-mediated hypersensitivity. So the second time you get stung by the bee, when the allergen comes in, now it actually binds to 2 IgEs, and that signals sort of 2x the signaling cascade to what's called degranulate for our immediate response. Degranulate means that there's these secretory vesicles inside of the mast cell that house cytokines like histamine. And they immediately fuse with the membrane and dump out the contents, and histamine causes its vasoactive response. Well, this is going to be immediate, but then you also have the ability for the late phase. The late phase is you start manufacturing these vasoactive compounds. From Unit 1, do you guys recognize this terminology of arachidonic acid? And it moves on to form leukotrienes and prostaglandins, which are vasoactive amines. They also have a role in our inflammatory cascade. But because you have to manufacture them from the phospholipid bilayer, that's where you get the arachidonic acid. Remember, there's a phospholipase that breaks down the phospholipid, turns it into arachidonic acid, and then you get your cascade of prostacyclines, prostaglandins, and leukotrienes, right? And thromboxanes. So all of those take time to make. It's like you got to bake the cake before you can actually release it or eat it. And so this is your late phase response. So the initial response is because of histamine, which is fast. And then the late phase response is because of these vasoactive amines. It's usually something like maybe 2, could be a little bit earlier than 2 hours, but usually it's a couple hours after the insult. And it can last all the way up for 8 to 10 hours from when that initial bee sting took place. Make sense? Yes, question?
So granule contents and secreted cytokines are both immediate?
Yes, the granular contents are the secreted cytokines. It's the same thing. Same thing. So these secretory vesicles house cytokines, or in other words, they hold contents within them that when they degranulate, they dump them out. Okay? And histamine is one of them. That's the first one on the list. That's the most important that I want you to think about. Yep. Okay, so let's look at some manifestations. What happens? Well, when talking about allergies, all of you kind of know what this list is. But let's just make a list for study purposes. Right? So you're going to get itching. Itching of the tissue because it becomes sensitized. This is a word referred to as pruritus. Pruritis. You get In extreme circumstances, you might get actual bronchospasms. You can actually get constriction of the airways. So if you have allergies and you have allergy-induced asthma, then you might be around a cat or a dog or a certain olive tree pollen, and all of a sudden you start wheezing. That's the bronchospasm. Laryngospasm, that's the larynx actually closes, and then some patients have trouble speaking. Right? They can't even yell help because their airways close off. This happens pretty commonly in a lot of food allergies, like shellfish allergies or penicillin allergies, is the airways actually close off, not just at the level of the bronchi, but at the level of the throat. I'll show you a picture in a second. Edema, that's just tissue collection, or fluid collection in the tissue, excuse me. Conjunctivitis is redness of the eyes. Rhinitis, runny nose. In some cases, some severe cases, you can get hypotension. So the blood pressure drops because the vasculature dilates so much. Right? Some of you have very low blood pressure, right? And if you take a hot shower or a hot bath and then you get up or out of the shower too quickly, you might faint. Well, why is that? Because when you take a hot shower, your blood vessels dilate. And so if your blood pressure is already low to begin with, it might actually drop even further. Okay? So hypotension can happen because of the tremendous vasoactive response of histamine. There could be gastrointestinal cramping. Why? Because blood flow to the GI tract actually drops in that case. You shunt blood away from the gut. It's not a time to digest a meal, and you actually push it and shunt it to other areas of the body. We'll see a lot of cellular infiltration into the tissues that are affected because of that dilation. And the gaps between the endothelium are so large that allows a lot of circulating monocytes to get out in this inflammatory response. If you get a lot of tissue macrophages out in the periphery, it actually leads to some tissue trauma. And then the mast cells, one of the secretory contents in those vesicles is a compound known as interleukin-13. Interleukin-13 or IL-13 actually influences the epithelium to release and secrete more mucus. And so you get a lot of salivary mucus that is upregulated in this IgE response. All right, so some pictures, an example of a type 1 hypersensitivity. This is an image down the normal larynx. You can see the opening. The vocal folds are in white. And this is an individual who suffered from a hypersensitivity reaction to penicillin. So this is acute laryngeal edema. That's why all that tissue is swollen red. It narrows that airway significantly. It goes from the upper image down to this lower image. And this is an anaphylactic shock reaction, or an IgE-mediated response to a penicillin allergy. The other ones that would cause a similar type of response, maybe not at the level of the throat, like in the situation of a bee sting or a wasp sting, but definitely with food allergies. You would see like shellfish allergies, right? Any environmental allergies that you're allergic to certain types of pollen and pollution, as well as penicillin or other drugs that we're looking at here. Okay, so type 2. Type 2 is shifting very differently from an IgE-mediated response. In type 2 is we've got a tissue-specific antibody binding. So in type 2, there's a production of IgG and IgM. And the example that we used was blood transfusions. But I'm going to characterize a different or another type 2 response of hypersensitivity. And this is post-streptococcal infection. So in the case of this situation, you see this patient has a sore throat. They test positive for strep. And the body itself, believe it or not, if you have strep throat, you eventually can get over it, right? If you're healthy. Your body's going to make anti-strep antibodies. Your B lymphocytes specifically are going to move into the lymph nodes, start interacting with the strep antigen, and make circulating antibodies all by yourself. But of course, in Western America, we can't wait for that to happen because you feel pretty lousy. And then you can't play like ultimate frisbee and take your exams and go to the movies. So we go get prescriptions for strep throat. Okay? But it's not a bad thing because this actually could be quite deleterious if it's left unchecked. So these antibodies also find targets in the body where there's cross-reactivity. So the antibody was manufactured for a specific type of antigen. For example, strep. And so it makes anti-strep antibodies. But it circulates throughout the entire body for a long period of time, and it has some non-specificity of binding. It finds other tissues that it can actually bind to, and some of those tissues are very localized at the heart. And so we end up having these anti-strep antibodies cross-react with certain tissues, like within the heart. There's no strep here. It's just that the myocardium is expressing some type of antibody or antigen that the antibody sees and the key fits. And in that situation, most commonly we result in what's called a myocardial Ashkoff body, which is a little scarring of the heart where that inflammatory reaction took place. There's two other types of things that are less common that we see on the heart as a result of this. We'll see at the level of the papillary muscles some of these little vegetations, these little scarrings of where the antibody is bound. Or in some rare circumstances, we get this pericarditis that surrounds the entire pericardium. So what does this Ashkoff body type 2 response look like? So this is cardiac myocardium in this H&E stain. And this structure right kind of in the middle, it has a lighter pink coloration to it. This is an Ashkoff body. So Ashkoff bodies are these nodules of scar tissue. They are a result of inflammation in the heart muscle due to nonspecific binding of circulating antibodies from a type 2 hypersensitivity. They were co-discovered independently, but almost at the same time by two individuals, Ludwig Ashkoff and Paul Rudolph Geipel. And so in the early days, they were referred to as Ashkoff-Geipel bodies. We kind of lost the Geipel, sorry for Paul, but he's dead, so we can't actually complain. So now they just call them Ashkoff bodies. It's kind of harsh, but that's what happens, right, within science. There's probably some really interesting political background story behind that. Some family donated more than the other, and then got it named after them. But we're actually moving away from a lot of these name terminologies. I don't know if you've noticed that. We're using more standard terminology in the medical literature, but I still like all these, old names that are associated with some of these terminologies, like this one. So Ashkoff and Geipel are the first ones that discovered them. So really what they are is they're a location of inflammation that results in scarring. And so you can see this scarring or this remodeling of the heart as a result of this circulating type 2. Okay, in type 2, what are some of the outcomes that can take place? Well, if you've got this circulating antibody, you can actually signal a phagocytic cell to come engulf that cell that's displaying the antibody. So that's one possible outcome, is phagocytosis. A second one that we kind of looked at with the Ashkoff bodies is inflammation in local tissue, where you find this antibody binding. So in inflammation of the tissue, we again see our complement or our accessory proteins manufactured by the liver, and this complement helps to activate C5a, C3a, activates our neutrophils, and our neutrophils move on forming reactive oxygen species, releasing a number of different enzymes, causing an early inflammatory response within that local tissue. And then the last example that I want to characterize, so we got a couple of examples here, just to repeat. We've got our blood transfusion example as a type 2, right? We've got our Ashcroft bodies as a type 2. And now we've got two more that we're going to look at that are in the category of type 2 hypersensitivity. The first one that I want to discuss is what we refer to as Graves' disease. So Graves' disease is at the level of the thyroid, and it's brought on by overstimulation of the thyroid gland by TSH, thyroid-stimulating hormone, mimicking antibodies. So here you've got a thyroid epithelial cell that's going to be releasing T3 and T4. And your body manufactures an antibody against the thyroid-stimulating hormone receptor. It binds to that receptor and it turns it on, chronically almost. And so now you start making too much T3 and too much T4, and this is a situation considered known as Graves' disease. It's also known as hyperthyroidism, overactive thyroid, hyperthyroidism. These patients suffer from an increased basal metabolic rate, elevated heart rate, severe weight loss, sleeplessness. They can't fall asleep. It's hard to relax. And then they have sort of what they call this eye disease, where they have this kind of bulging eye syndrome. We're going to look at this in more detail in later sections when we look at endocrinology. But I'll come back to it, I'll point back to this lecture, so this is kind of foreshadowing to where we're going later on. But this is a type 2 hypersensitivity, because you're manufacturing these antibodies to this TSH receptor, and they bind to that tissue. Now, the last one, or the fourth one that I want to showcase, is known as myasthenia gravis, and this is at the level of the muscle. So myasthenia gravis comes from a Greek-Latin combo. So from the Greek, the myasthenia gravis terminology is referring to muscle, and then the Latin gravis is serious weakness. So it's severe muscle weakness that takes place at the level of the neuromuscular junction. So what we have going on here is, this is on the presynaptic side. This is our end knob, or our terminal button. Here are our little vesicles that house acetylcholine. They release into the cleft, and they should bind to the acetylcholine receptor on the postsynaptic terminal. And this is at the muscle, so this is the nerve, this is the muscle. And when those acetylcholine neurotransmitters bind here, you propagate your action potential. Remember that from 201? Well, in patients suffering from myasthenia gravis, you get an antibody that binds to this receptor, very similar to it binding over here. But in this case, it actually competitively inhibits. So it binds to the receptor and prevents neurotransmitter acetylcholine from binding. And if it can't bind, then you can send the electrical signal down the neuron, but the muscle never gets the neurotransmitter to do anything on the other side. And so you have sort of this muscle wasting or this muscle weakness. Even though the nerve is firing the action potential, you've got this blocking antibody that you've made as a type 2 hypersensitivity. Right? You're making antibodies against your own receptor. Here you're making antibodies against your own TSH receptor. Here you're making antibodies against your own acetylcholine receptor. You're not supposed to make antibodies against those things. You become hypersensitive to something that is your own part that you should not be making antibodies against. Make sense? So in the last lecture series, we talked about screening out poor behaving B cells and T cells. You guys remember that? And we talked about central and peripheral tolerance. And at the level of central tolerance with both B and T cells, We try to eliminate those that are self-reactive so that they don't do this kind of thing. But it's not perfect. And remember, with B cells, there is no peripheral tolerance, only central. So with B cells, when you make a B cell that's self-reactive, it's going to find tissues in your body and make an antibody against it. And you don't screen it centrally, and it's leaky, it makes its way out. That's when you're going to have an autoimmune disorder. And that's when you're going to have a hypersensitivity. Okay? And so the inefficiency or the inability for us to find those self-reactive B and T cells is what causes this condition that we're talking about today. Does that help connect some of those dots? Okay, so type 2. Now we're transitioning to type 3 and 4, hypersensitivities. And in type 3, we form a complex that circulates. So most students struggle with the differences between 3 and 2. Because in 2, where we just were, we make an antibody that circulates around and finds something on a piece of tissue and it binds to it. At the neuromuscular junction, at the thyroid epithelial cell, okay, on the heart tissue, on the red blood cell. But in type 3, we make an antibody that gets into the bloodstream and it finds a antigen and then it starts to precipitate or agglutinate. And that structure is what gets lodged or stuck somewhere. That complex circulates around and gets stuck somewhere and causes an inflammatory reaction in that end tissue bed. So most of the common places that you're going to see type 3 are areas where you've got blood filtration or blood contact. So things like the kidneys, in the wall of the blood vessel itself, and then joints. And some of you are like, well, joints, why in joints? So think about rheumatoid issues. But the joints, because the synovial joints are full of synovial fluid, right? Remember that? And that fluid is very similar to blood plasma. There's typically no cells in it. It's very lubricious because you're trying to actually keep moving parts from friction, but it's basically clear and colorless. And so you generate synovial fluid by filtering the blood. And so if you filter the blood and one of these complexes ends up within the joint, then you're going to actually have type 3 hypersensitivity. Okay, so if you look at this picture, you can kind of appreciate this is a blood vessel. Here's our free antibody, right? Living free. Woo! Circulates around, binds into an antigen antibody complex. And this thing gets stuck in the blood vessel wall. And now the neutrophil comes around, sees it, and starts an inflammatory reaction in the wall of the blood vessel. And this is a condition known as vasculitis. Now, if we get this taking place at the level of the kidney, then we get conditions known as glomerulonephritis. And we'll talk about that in our renal section a little bit later. So I'll bring up some glomerulonephritis like acute and chronic glomerulonephritis later in the renal section. And we'll point back to a type 3 hypersensitivity that we learned about today. So we've got vasculitis, glomerulonephritis, and then arthritis that we refer to as reactive, not rheumatoid. Reactive arthritis due to this complex that forms and gets lodged in the level of the joint. Rheumatoid arthritis, there's all sorts of different types of arthritis, just so you know. So rheumatoid arthritis is a type 4 reaction. There are antibodies involved, but there are T cells, and that makes it a type 4. Okay, so this arthritis is referred to as reactive arthritis, which is really confusing because that would be abbreviated RA as well, right? But you don't abbreviate reactive arthritis as RA because RA is reserved only for rheumatoid. Okay, So type 4. The first three that we just described and talked about are antibody involvement. Right? B cells manufacturing antibodies. IgE in a type 1, IgG and IgM in a type 2, and a variety in a type 3. It's not exclusive to any one category. Type 4, the biggest important factor of a type 4, and at the end of the lecture I have a great summary chart for you to study from. But the most important feature of a type 4 is that you have T cell involvement. It could be CD8 or CD4. So you can see that there's a CD4 component here releasing cytokines. There's a CD8 component here releasing cytokines. And this is more of a delayed type where those cytokines stimulate circulating inflammatory cells to move in and target the tissue. The T cell mediated cytolysis is where the CD8 cells, referred to as cytotoxic T lymphocytes, directly attack the tissue that's displaying the antigen. Okay, so we have both mechanistic pathways that are operational, but there is a T cell involvement in both pathways, and that's the most critical thing. Most oftentimes, though, we see a delayed type of response, like the top one. But when we see cytolysis, like in transplant rejection, while it's a little bit more rare, it's also extremely fascinating. So let's talk about some of the examples of type 4 hypersensitivity. Somebody was just in my office asking about Crohn's disease this afternoon. Right? And I'm not sure if it was because you read ahead, but they have a friend that wrestles with Crohn's disease. So what is it? Crohn's disease is an autoimmune disorder. Okay? So at some level, there's a leakiness of the immune system where an individual suffering, this isn't a picture of Crohn's, you're like, this looks more of an armpit than the intestinal system, right? You look real carefully to try to find the intestines in that picture. So that's actually contact dermatitis right there. Okay, like what you would see with poison ivy or poison oak. But we'll get there in a second. So with Crohn's disease, this is a immune system is developing T cells that are attacking the gastrointestinal tract. And it causes inflammation. And it has episodes, long-lasting episodes of IBS, inflammatory bowel syndrome. And that might be chronic, it might be short-lasting, but it's throughout the lifetime of the patient. Okay? Contact dermatitis. This is a exposure to certain types of allergens that are actually going to be stimulator and manufacturing T cells in order to cause that reaction, like what you would see with poison oak or poison ivy. MS, multiple sclerosis. This is a inflammatory disease, but the body itself, the immune system, is attacking the fatty sheath or the myelin around myelinated neurons in the central nervous system. And so over time with MS, you erode the myelination and you significantly decrease the velocity of the action potential. And so patients actually progressively decline over time with MS. Let's see, type 1 diabetes. I got more on my list of notes than what's on the slide. So diabetes mellitus type 1. In the older literature, we used to call this, bless you, we used to call this, not bless you, but we used to call it juvenile onset of diabetes or child diabetes. But that's not really a term that we use today. Because more and more patients are showing up in their late teens or in their 20s or 30s with type 1 diabetes that was undiagnosed and it was actually non-clinically manifested until some sort of stimulus. We had a family friend, we were away on family vacation and we were up in the Santa Cruz area We go there every year, and if you've ever been to Santa Cruz, they have this boardwalk. And it's kind of like this, it's a pretty famous boardwalk, the Santa Cruz boardwalk. Any of you see the movie Lost Boys? So that's where the movie Lost Boys was filmed, and that's the boardwalk scene. So like Tuesday, I think it's Monday and Tuesday night, we have dollar rides. And so we'll take the kids to the boardwalk, because that's the cheap night to go. But then they have like funnel cakes and cotton candy. I mean, it's like a state fair almost, but it's just like a boardwalk. Well, we have this family friend, healthy, college age. He was 20-ish, I think he was about 20, and played basketball, in good shape, athletic, basketball morphology, basketball build, and ended up having like 3 funnel cakes one night, and started feeling really, really bad. And as the night went on, and he kept eating the funnel cakes, he started getting worse and worse. His vision was narrowing. Not just to the point that he was going to throw up, but to a point where he felt like he was going to pass out. Well, he actually passed out. We called the ambulance. Ambulance came, and he had a blood glucose level of about 700. And he went to the ER in Santa Cruz, and they diagnosed him with diabetes mellitus type 1. He was 20 years old. Right? He was fine his whole life. But that incident was sort of like a stimulant that just shocked his physiology. Like 3 or 4 funnel cakes in one evening, he was right on the cusp of not being able to manufacture enough insulin. And that's what pushed him over the edge. Okay? So diabetes mellitus type 1 is no longer really considered juvenile. I wouldn't consider a 20-year-old juvenile. Okay? And diabetes mellitus type 1, in this situation, your body is building a T-cell response that's attacking the beta islet cells of the pancreas. And that's what manufactures the insulin. And if it happens slowly over a 20-year period, then maybe in the beginning, when this family friend was, say, 18 months, years of age, maybe like 95% of the beta islet cells were operational. And then by the age of 10, maybe 70%. By the age of 15, it might have gotten down to like 50%. And by the age of 20, maybe only 35 to 40%, I'm making up these numbers, 35 to 40% of the beta islet cells were functional, and 3 or 4 funnel cakes at the boardwalk was just enough to trigger it into a sugar coma. Okay? So a lot of these disorders, MS is the same way. We're going to look, lupus is the same way. We tend to blame genetics and some environmental trigger that pushes the patient over the edge when they start manifesting symptoms. So a patient says, some patients are diagnosed with MS very early in life, some are diagnosed very late in life. And so what's the consistency? There is none. That's the consistency, there is no consistency. And a lot of times it's the genetic profile, and then there's some sort of environmental trigger that pushes that patient into a clinical symptomatic condition. All right, the last one on the screen is what we refer to as Hashimoto disease. Hashimoto disease is one of the first diseases discovered by a Japanese physician. You couldn't tell. And Dr. Hashimoto first described this thyroid disorder. So this is a hypothyroidism, Hashimoto's, where you've got a T-cell destruction of the thyroid cells. Another one that's now popular, I need to add it to the slide, but go ahead and do it. There's a little white space at the bottom. Is celiac disease. Because celiac disease is a disease, students like to say, oh, it's like a new disease, like it just showed up. No, it's been around for a long time, like many of these diseases, but we're just now becoming more aware of what it is. Right? So, cancer, in this room, probably everybody has been impacted by cancer in one way, shape, or form. Okay? Even if it's I had a friend whose mother or father or a grandparent. But it's probably closer to that. And if you wind the clock back 50 years ago, I wasn't alive, thank you very much, but 50 years ago, in this same type of classroom, this classroom, believe it or not, was here, the incidence of cancer was not nearly what it is today. Now, is that because cancer prevalence has increased, or because our knowledge and our awareness of what is cancer has gone up? How do you prove either one? But I have a feeling it's probably the latter of the two. Is that cancer's been around taking humanity down for generations. But we're just now becoming sophisticated enough to know what it is. So celiac disease. Celiac disease is typically referred to as a type 4 hypersensitivity because there are T cells that are recruited and involved in the onslaught. The T cells attack the lining of the small intestine, and it prevents it from absorbing parts of the food that are necessary for staying healthy, and so they become malnourished. Many times, but not all, but most of the time, the damage is due to a gluten response. So gluten, even the smallest trace amounts of gluten, okay, which isn't really an allergy to the gluten, it's a T cell response to gluten. That's why just a little bit of gluten triggers the response, because it's T cell mediated and it's not an antibody production. Make sense? And if it was antibody production, some of you that are allergic to cats know, you could walk into a house that had cats and you know there's cats there, but as long as you don't touch anything and then don't rub your eyes, you're fine. But if you go pet the cat and then rub your eye, it goes like, you go blind, right? You're like, ah. So you know that at the level of antibody response, there are phases, or there is definitely a dose response. In celiac, it's not the case. That's why they have to be so careful when they go to a restaurant and say, oh, we're gluten-free. That may not work. It could be gluten-free, but they use the same, utensil or pan or sink or oven, and a little bit of gluten got in there, and that's all it takes in some of these severe cases. So a type 4 hypersensitivity, incidentally, gluten is found in just about everything. I think it's an error. So I have a close friend who's got a son who wrestles with celiac, and it's tough. It's really tough for them. They got like one restaurant, they don't live in town here anymore. They have one restaurant in their neighborhood area, region, that they can go to that actually is very good about segregating the kitchen. They originally lived in the flat. We started a company together, and they had to leave. And he was heart sick, but he had to go because of his son. And they originally thought the son had a cardiac issue and was responding negatively to the altitude. And it was misdiagnosed by 4 different pediatric specialists in Flagstaff, and it was celiac disease the whole time. So it's just, it should be on the list now because of this recent experience of ours, but you have the information that you can write down. Okay. Any questions so far? So let's talk a little bit about, in the categories of hypersensitivity and autoimmunity, what goes on with a transplant rejection. So a transplant rejection is a type 4. It's another example of a type 4. You could add it to that list. And there's 2 big things that can take place in transplant rejection. So the first one is what we refer to as the direct pathway. And in the direct pathway, the antigen presenting cell in the graft is the donor tissue that's coming in, likely has antigen presenting cells still within it. You don't flush them out before you donate the organ. So that antigen presenting cell is going to be able to present both a class 1 and a class 2 MHC response. If it's a class 2, you remember we go down a CD4 pathway, triggering helper T cells and the development even of subsequent antibodies. And if it's a class 1, we know it goes down a cytotoxic T lymphocyte pathway and results in an endothelitis of the vessels in, this is a kidney transplant in this example, in the kidney, or actually the renal tubule just gets attacked and destroyed. If it's an indirect pathway, meaning that the graft cells have some antigen that they're expressing, and the recipient, or the person receiving it, their tissue, their antigen-presenting cells find those antigens, and the APC of the recipient shows it to a CD4. Now you start building a plasma cell response to develop antibodies that circulate and destroy, ultimately, the donor kidney. So how do we block this, right? So this is a type 4 type 4 hypersensitivity, but it could involve antibodies. That doesn't throw you off because you know it's type 4 because there are T cell involvement. So in type 4 with T cell involvement, how do we minimize or eliminate this type of response? Well, the way that we do this, if you back up to the last lecture series, we're at the level of the lymph node. This is a review slide at the level of the lymph node. We're blowing up this mechanistic pathway where we've got our CD8 positive T cells that are going to be presented an antigen, and then they become cytotoxic T lymphocytes ready to go out in the periphery and kick some butt. Well, before they go there, right here at this step, there's this intermediate step of interleukin-2 co-stimulation. Do you remember that? So this interleukin-2 co-stimulation is what allows these cytotoxic T lymphocytes to turn on. So it's not enough that they just see the antigen. They also have this co-stimulation event to activate them. And that forms a population of effector T cells that go out in the periphery and kick butt, and memory T cells that stick around for the next time they see that antigen. Well, we can deliver co-stimulation blocking drugs and prevent that co-stimulation event from taking place. And we use what we call immunosuppressant therapy in transplant patients. They're getting a transplanted kidney or a transplanted heart. Okay? If they're getting a transplanted trachea or tissue, you've seen some pretty amazing face transplants being done in the media, right? Where these are traumatic events, a dog attack or a burn or some issue that shows up, and they transplant a face from one person to another. Well, those patients will reject that donor tissue unless you use immunosuppressant therapy. And one of the classic ones is known as cyclosporin. And cyclosporin blocks interleukin-2 and prevents the tissue, the host, from rejecting or harboring a rejection response against the donor tissue. But if you don't give cyclosporin, what happens? Well, that's these pictures. So this is at the level of the kidney. This is the kidney glomerulus in A. So we're seeing the early hyperacute rejection of a kidney allograft. Allograft meaning same species, but not same patient. That would be an autograft. But it would make no sense to take your left kidney and put it on your right side. Okay. So, the rejection is CD8, CD4 mediated. We have T cells, so we know it's a type 4. Type 4 hypersensitivity. Here in B, you can start seeing all the new purple inflammatory cells that have moved in from panel A into panel B. And then here you can start seeing in panel C, you start getting this rejection vasculitis. You're starting to see an inflammatory response at the level of the blood vessels. And then in panel D, the far right, you've got graft arteriosclerosis. So the vascular lumen, this is a blood vessel right here. You see this blood vessel? This is the lumen, that little white area. This whole area should be white. But all of this in the blood vessel is the vasculitis that's building up as a result of this rejection response, and now you're going to lose the organ. So, type 4 hypersensitivity is classically described by transplant rejection. Transplant rejection. So let's just finish up this last little section, and then we'll take a break. The autoimmune diseases that I want to characterize at the very end here from a mechanistic standpoint are going to be lupus. And I want to pause for a second and back up to our last lecture series. And I mentioned it earlier, but I want to mention it again because it's so important. Because some of you are scratching your head going, wow, this sounds really, really crappy. Like, that sucks. Like, why does that happen? Like, what in the heck is going on? Like, why is that going on? Well, so remember, when we make our immune system, right? So let's back up even further. What's our primary line of defense? What's our first line of defense? Barriers, thank you. Barriers could be skin. Barriers could be mucous membranes. They have enzymes. Hair, okay? Cilia. So believe it or not, you have this respiratory escalator, right, in your lung epithelium. And all day long, stuff gets trapped in there. And those little cilia have this reverse sweeping motion. So every time you clear your throat, right, and then you swallow that loogie, which is where it goes, right? Kind of gross, but that's what happens. You're clearing out all of those foreign contaminants that were trying to get in to your lung area. So primary line of defense, first line of defense, skin, barriers, okay, physical barriers. Second line of defense, inflammation. Those two collectively are part of our innate immunity, right? They're the same every time. They don't change. We don't modify them. And then we get into what we call adaptive immunity. Adaptive immunity, or specialized or specific immunity, is where we make B cells and T cells. And we make them to target the variety of things that we're going to come in contact with. And in order to forecast all the different things that we possibly could come in contact with, we have to be very creative and clever about manufacturing a diverse population of B and T cells. Remember? And when we make a diverse population of B and T cells, in both of those populations, usually 90% of the time we get it wrong. And it reacts with something within our body. But we catch it. And then we back up and we say, you know what? I don't want you to go out in the periphery. I'm going to not let you go out in the periphery and cause a problem. 90% of the time, that's what happens. And we have to try all over it. Only 10% of the time do we get it right. We release a B or a T cell that is non-self-reactive, but it's very, very clever about finding all the diverse antigens that we might experience. But with those numbers, does it surprise you that every now and then we have a breakdown of self-tolerance mechanisms? It shouldn't surprise you, because we're trying really hard to forecast or predict what are we going to see in our environment. And it's a rough environment that we live in. And so the trade-off for that is every now and then a self-reactive clone gets through. And we have an autoimmune disorder. And that's what we're talking about in this lecture series. Okay? So, how does this all happen? Well, we have a breakdown of self-tolerance mechanisms, and we make clones that are self-reactive, and then we put them out in our circulation. And they go and they attack our intestinal tract in Crohn's disease. Or they go and they attack our beta islet cells in diabetes mellitus type 1. Or they go out and they become overly sensitive to certain types of pollens or antigens. Or they go and bind to thyroid-stimulating hormone receptors on thyroid epithelium. Right? Want to bet 10, 20, 30 years from now, when you guys are in the field, we're going to come up with new autoimmune disorders that we've discovered. They've probably already been there. But like in the last 10 years, we think we discovered celiac disorder. Do you see what I mean? It's probably been around, and in 10 or 20 more years, we're going to find a new set of autoimmune disorders that are just not in the textbooks right now. Okay. So if we look at lupus, if we look at lupus, this is systemic lupus erythematosus. This was the slide I was alluding to, where we've got what we call two initiators. We've got definitely an inherited susceptibility. You can fill in the blank here. It's not just lupus. This is a flow chart that almost could be used or modeled for a lot of the autoimmune disorders we talked about. Crohn's disease, is there a genetic component? Absolutely. MS, is there a genetic component? Yes. However, we cannot ignore that there's likely some sort of environmental trigger that stimulates. Remember the funnel cakes and the example of that one family friend? So these environmental triggers would be different or unique, right? It'd be funnel cakes instead of UV radiation, okay? But in the case of systemic lupus erythematosus, or SLE, we've got an inherited set of genes, and then there's been evidence to suggest in the literature that overexposure to UV light or UV radiation can aggravate or can stimulate the first onset of symptoms. Now, then we move on to looking at the antigens that are usually nuclear proteins that we're reacting to. And then we start stimulating both T and B cells to target different types of tissues in the body. Depending upon the type of lupus, we see different manifestations. So there's really four main types. We've got the systemic, which is really the most aggressive. Then we've got cutaneous, which is basically skin only. Cutaneous, otherwise referred to as discoid. Then we have drug-induced lupus, and we also have fetal. So we've got our genetic and our environmental susceptibilities that trigger this. And in the case of lupus, it is one of the more common autoimmune disorders that we see. We've got about one case in about 2,500 people in the population. And I already told you that UV light tends to exaggerate or exacerbate symptoms. So if we look at SLE, we see system-wide issues. We see acute necrotizing vasculitis. We see swelling in the joints. We see redness at the level of the skin. Skin erythema. Erythema is a word that means redness. This is what's called a butterfly rash on this young patient that usually is over the bridge of the nose, and this is kind of a telltale sign of an SLE patient. There could be CNS involvement, and then of course we've got issues associated with the kidney, glomerulonephritis. So it is systemic, as the name would imply, systemic lupus erythematosus, and it is classically described as a type 3. Although in some textbooks, if we see a T cell involvement, we would call it a type 4. Okay, so for purposes of our class, we're going to call it a type 3. But I just want to make sure that you understand, in some rare cases with lupus patients, we actually see T cell involvement. And then in those cases, you would also refer to it maybe as a type 4. So it might be a type 3-4. But for our purposes for the exam, we'll call it a type 3. Okay? All right, so one more example that I want to talk about as we wrap up this lecture is rheumatoid arthritis. Rheumatoid arthritis is a type what? What is rheumatoid arthritis? Type 4. So we're going to get B cells, but we have T cell involvement here, almost always. And the etiology is believed to be at the root of an erythrogenic agent that's found in the joint capsule. And that currently today is being blamed on collagen type 2. So we've got CD4 cells that are activated in the joint. They move on to stimulate B cells, macrophage activation, as well as endothelial activation. And as we move down the cascade of events that can take place, we see our B cell activation, our macrophage activation, as well as endothelium. All of these are going to have mechanistic pathways that cause the end problem. The end problem is this ingrowth of what we call the pannus formation. So the pannus formation is where we lose bone, we lose cartilage, and we replace it with an inflammatory response and fibrotic scarring. That fibrotic scarring gets so aggressive where you lose the joint space, and then you get what we call ankylosis, which is a word that actually means bent or crooked. And so patients with rheumatoid arthritis kind of have that classic, the finger goes like, "Warm, warm." Okay, and that's because of this inflammatory response that's shown in this picture. Oh, sorry, too many. My button happy over here. Okay, so in this diagram, we've got on the left side of A, we've got a normal joint. On the right side of A, we've got a rheumatoid joint. And you can kind of appreciate the integrity of the open white space, right, which is part of the capsule. We've got synovial fluid that fills that space. We've got our nice intact synovial membrane, and then we've got cartilage on our articulating surfaces. Over on the patient's left or your right, you start seeing this pannus formation that takes over that void space. We bring in these macrophages, as well as neutrophils, then macrophages, and then we actually have our dendritic cells and plasma cells that are present, antigen-presenting cells, as well as cells able to manufacture antibodies. All of this activity starts leading, this is what that tissue starts to look like. You see this infiltration of these inflammatory mediators. Here we've got lymphoid tissue in the red arrowheads, lymphoid tissue where you've got a collection now of T cells in the joint itself. So at the level of the joints, you get this ankylosis or this bent. At the level of the skin, rheumatoid arthritis doesn't just stay in the joints. It moves all around the body. So you'll get these rheumatoid nodules that will show up in patients in the skin. You'll get obstructions, like a vasculitis that shows up in blood vessels. And then on x-ray or radiographically, we start seeing things like this. So this is this joint in one patient right here. Okay? If you blow that up, you've got breakdown of the bone. You see how the bone is eroding? And that's because of what is going on right here. You see how this is eroding the bone up here? And this is eroding the bone down here? And that's what you're capturing in this radiograph. Another situation in a different patient that's shown over here in panel B, this is that pannus. You've lost the joint space. You see how these joints right here, there's some dark black in between? Over here it's white. It's white because that's the pannus that's actually present. So in these patients, we see not just the joints affected, but also the skin, also the blood vessels. We see this ankylosis, where we lose the joint capsule. It's replaced by inflammatory pannus. It targets typically the small joints first. That's why the hands, that's why you notice it in elderly patients in their hands. And then it moves to larger joints next. It's also symmetric. So rheumatoid arthritis, if this hand has arthritis, a lot of times this hand does too. And you'll see patients where the fingers kind of bend almost symmetrically in the same direction. Not to be confused or in contrast to osteoarthritis. Osteoarthritis is a wearing of kind of a rubbing motion, bone on bone. Osteoarthritis is not symmetric. So old professional pitchers or quarterbacks will get osteoarthritis in their throwing arm, but the other arm's fine. Okay? So that's a wearing out of that interface, not necessarily an inflammatory response triggered by the immune system. So osteoarthritis is very different than rheumatoid arthritis. And then the rheumatoid arthritic factor, collagen 1 is what we think it is, has been identified in 80% of the cases today. 80% of the cases take, which makes sense. It makes sense that there's some breakdown in an autoimmune pathway that's causing you to manufacture self-reactive clones that are making antibodies and stimulating a T-cell response against your collagen II. And collagen II is found in the basement membrane of the blood vessels. It's also found in the skin, not just in the joint. So that makes sense as to why it's all over the body. It's not just at the level of the hands and the feet or the joints. So the summary slide that I wanted to share with you is here. This is not in your textbook, so I went ahead and put it up here for you. Table 5, you won't find it in your textbook. It's from a different medical text. But I think it does a really nice job of helping you compare and contrast the different types of hypersensitivities. So the columns, the second column is type 1, the third column in the middle is type 2, type 3 is the fourth column, and then the last, fifth column on the far right is type 4. And then you've got examples that go in the rows across on the bottom, and you can see some of the ones that we've talked about, like type 1, allergy and asthma. Type 2, we've talked about, well, those are different than what we talked about. Type 3, there's where the systemic lupus erythematosus is listed. And then type 4, we've got poison ivy as a type 4. Okay? Questions or comments before we take a break? Okay, cool. See you guys in like 10 minutes, 5 minutes.